So here's lesson 20 in our EMT course. It's in the cases D unit. We're going to deal with shortness of breath patients in this lesson, and the next one is on sepsis and septic shock patients, and that comprises the D unit. This one's a 6-hour long lesson, one of the more deep or thick lessons in the EMT course. We see a lot of respiratory patients, and there's several things for you to know. We're going to talk about some anatomy and physiology review of both respiratory and circulatory system, and then get into the specific causes of shortness of breath, how you assess those and treat them, and we'll talk about cardiogenic shock as well. So, respiratory system anatomy review, it's basically an upside-down tree where the trachea would be the trunk of the tree, and then you have limbs that branch off of that, and then smaller and smaller limbs, and eventually twigs, and then you get to the leaves, the alveoli being the leaves on that tree. A key point with this is that these conducting airways are the tubes only. There's a dead space concept we want to talk about. So what this means basically is that the airways that take air to the alveoli are called conducting airways. And they have muscular walls. They're under the autonomic nervous system control, meaning automatic, more or less. You can't really think that I want to constrict my bronchioles. The autonomic nervous system takes care of that, so sympathetic and parasympathetic nervous systems. And this is pretty much automatic, but sometimes you can have an inappropriate constriction of those conducting airways, and bronchioles in particular. The bronchioles will constrict, and so bronchial constriction can cause obstructions in the lower airway, and that's just kind of a foundational A and P sort of concept. And then remember that only place that oxygenation actually occurs is in the alveoli. The leaves on the tree have to get the air. It doesn't do any good for us to get air just into the limbs and the twigs. It's got to get all the way to the leaves, because there is no gas exchange that's going to occur until you get to the alveoli. And so that's this dead space concept. Dead space means that you're only ventilating the conducting airways. You're not actually ventilating the alveoli. And so dead spacing is something for us to consider as we go through some of this. Respiratory system you can divide into upper and lower airway. Upper airway must be patent in order for us to get good ventilation to the lower airway. Upper airway obstructions most commonly are the tongue, and then there are, of course, foreign bodies, and then also swelling, an inflammatory response, or as a direct result of some insult such as inhaling superheated gases or something, more commonly from an allergic reaction where you have swelling in the upper airway. And the lower airway obstructions can be caused by three things. This is a key concept. You should make sure you understand this. Bronchioles can obstruct because of mucus production, excess mucus production. Our respiratory tree is lined from top to bottom with snot, and snot, mucus, more or less the same thing. And if the mucus is thick, then it can be harder for that mucus to be moved up and out. So as you cough, and you move that mucus out of the respiratory system, but if it's real thick, then it can adhere to the bronchioles and build up, and you can actually obstruct just because of mucus. There can also be an inflammatory response going on where you have tissue inflammation in the bronchioles. Again, that's an allergic sort of response, asthma related, or an anaphylaxis problem, and the inflammation can also totally obstruct a bronchiole. So when you add mucus with inflammation, you can see how you can pretty much obstruct a bronchiole just with those two things. Then the bronchial walls are muscular, as we said in the previous slide. They're under control of the autonomic nervous system, and at times the autonomic nervous system will cause your bronchioles to constrict some or to dilate some. And when that system's out of whack, you can have inappropriate bronchial constriction. So why would a bronchiole obstruct? Well, it could be plugged with mucus. It could be that the walls have narrowed because of inflammation, or it could be the walls, the muscular walls have actually constricted. Then in the lower airway, there's also the alveoli. Alveoli can be obstructed by mucus, by pus, as in pneumonia. They can be damaged, as in emphysema, and damage from smoking or smoke inhalation. And they can also be full of fluid from blood not being pumped away. Now, we've spent a fair amount of time tracing the path of a red blood cell, and that's so that you can understand the concept that if the left ventricle is not pumping because of heart attacks or some short-term insult where the left ventricle is not pumping, then blood's going to back up into the pulmonary vein, into the pulmonary system, and back up and flood the alveoli. And so the fluid part of blood, and in some cases some blood cells, will end up being in the alveoli because basically things are flooded and the pump is not working. Speaking of the pump, the circulatory system, as you know, has the pump, fluid volume, and the container. And so again, the concept of being able to trace the path of that red blood cell all the way around helps you learn what pipes connect to what parts of the pump are connected to what hoses. And it gives you an idea of how to troubleshoot the system when you find various things. So shortness of breath, the technical term being dyspnea, D-Y-S-P-N-E-A, nia meaning breathing, and dys meaning difficulty breathing. Patients don't call and say, I'm having dyspnea. They call and say they're having shortness of breath. That can be caused from a number of things. You could be just from exertion. Could be due to pain. Maybe there's a chest wall injury of some sort and it just hurts to breathe, and that causes you to feel a little short of breath. Could be an anxiety cause related to some sort of psych issue or short-term behavioral problem. An emotional stimulus has caused you to be a little short of breath because you're anxious. Shortness of breath could also be from hypoxia, and hypoxia can come from a number of things. Pulmonary embolus, we'll talk about here in a minute, could be just from shock, or anemia. Anemia would be when you are low on red blood cells. So even though you have normal blood volume, perhaps, you're low on red blood cells. Or maybe you have low blood volume, and so there just aren't enough red blood cells to transport the oxygen around. So a patient is hypoxic because they're not bringing in enough oxygen, or because they can't transport that oxygen to the cells. And then you can also have hypoxia due to upper or lower airway obstruction, and that's kind of where we're going to focus the rest of this lesson, but we wanted to talk about the other 4 major causes of shortness of breath to give you the full picture. But kind of from this point on in the rest of this lesson, we're going to talk about hypoxia resulting from an upper or lower airway obstruction. Again, as we kind of mentioned in the opening thing, upper airway obstruction, most commonly the tongue. The tongue's the most common airway obstruction in any age, in any situation, and you relieve that by positioning to have gravity work to the benefit of your patient, and then adding a manual jaw thrust. Foreign body removal through coughing. The patient can cough it out on their own. That's more effective. When they're no longer able to cough, we add an abdominal thrust, sometimes called the Heimlich maneuver, but abdominal thrust, and all we're doing there is causing a cough. And it can also be from swelling. There's just not a lot you can do with upper airway swelling at the BLS level, other than if it's caused by maybe an anaphylactic reaction and you're able to assist the patient with their prescribed, not expired, EpiPen, then that may work. ALS services have the ability to do some medication, some nebulized racemic epinephrine it's called, which is basically topical application of a vasoconstrictor, and so that may sound like a mouthful, but you've probably used nose spray. You spray a nose spray up your nostril, and that has a vasoconstrictor in it, and what that does is topically cause the tissue to shrink and open up some space for air to move, and that's kind of what the ALS folks are doing otherwise. But at the BLS level, even if you know for sure your patient has upper airway obstruction due to swelling, because you can hear stridor, the high-pitched crowing sound, you listen to it right over their Adam's apple, and you hear it and you know it, there isn't a heck of a lot you can do about it, unfortunately. Lower airway obstruction, however, really is the meat of this lesson, and so we're really dealing with bronchioles, in some cases alveoli, but mostly bronchioles. They can be constricted. They can, due to just bronchial constriction, kind of stumbled over that. The bronchioles can constrict. The muscular walls can contract. That can be one thing. Or you can have an inflammation that's built up, or you can have excess mucus. Now, what can you do at the BLS level for this? Well, bronchial constriction can be dealt with bronchodilators. And those are delivered via a metered dose inhaler, an MDI, a puffer, or an inhaler. Some services have protocols that include standing orders that allow you at the EMT level to assist the patient with their bronchodilator as long as it's delivered via a metered dose inhaler. And we'll talk about bronchodilators and inhalers here in a bit, but here's a sneak peek. Not every inhaler, not every MDI that a patient has is a bronchodilator. So you're going to have to know a couple of these common names and decide whether this metered dose inhaler is one that you can assist with or not. The patients will usually know. They have a rescue inhaler, which is their bronchodilator, and then they have a maintenance inhaler that they take every day no matter what, that has steroids in it usually. So if you notice that your patient has a lower airway obstruction, which you would typically assess by shortness of breath with wheezing, if you notice that and your protocols allow, and the patient has a bronchodilator that's delivered via an MDI, then you would be able to assist them with that. If the cause of the obstruction is inflammation, there really isn't anything at the BLS level that will work on that. ALS system, they have steroids, but those are given IV, and they have about an hour onset of action. So really they're giving the steroids in the field for the benefit of the patient when they get to the ER. So the medics have to deal with the same thing that you do, and that there's not much you can do for inflammation. Then the mucus could also be a problem, and there really isn't much that you can do at the BLS level for excess mucus, unless they have a bronchodilator that has a certain type of medication in it, which we'll talk a little bit more about later, and we'll show you in lab. But ipratropium is a medicine that is a parasympathetic antagonist, so that's another big mouthful. But what that means is that there is some benefit to the patient in terms of dealing with mucus if their MDI, bronchodilator, is a mix that includes ipratropium. Combivent, Duoneb, Atrovent are all bronchodilators that have the ipratropium medicine in it that has some effect on mucus, not a lot. They're mostly to get rid of bronchoconstriction, prevent bronchial constriction actually, but they do have a little bit of effect on mucus. Speaking of mucus, seem to be suffering the same thing. So lower airway obstruction can also be an alveolar problem. Smokers, people that have inhaled, say, coal mine dust or other lung toxins like that, have actually damaged alveoli. And that would be in your case of your COPD patient, your emphysema or chronic bronchitis patient. You can also have pneumonia. Pneumonia basically means your alveoli are full of infectious fluid, infected pus type fluid. And again, there's just not much at the BLS level that you can do. Some of those patients will turn into septic shock patients, which we deal with in the next lesson. But pretty much like COPD, there isn't a whole lot you can do for these folks. Sometimes the bronchodilators will help. And our rule will pretty much be, if they're wheezing, then let's go with the bronchodilator, regardless of what the cause of that wheezing is. And it could be COPD, it could be asthma, it could be some wheezing and pneumonia, there could be some wheezing and congestive heart failure. And so that's really, you have oxygen, you have ventilation, and in some cases you'll have authorization to assist if they have a bronchodilator. Now, you're not going to be carrying bronchodilators, but if they have their own, then you will assist them in some cases. Then congestive heart failure, basically there your pump is not pumping, the alveoli are flooded, and that can turn into cardiogenic shock, and there just isn't a heck of a lot anybody can do for that, and certainly not at the BLS level. So these shortness of breath patients, you'll see them a bunch. You'll see the same patient over and over, and some days they're real bad and some days they're not as bad. They usually don't call us until they're pretty bad. They're short of breath most of the time, and then really short of breath sometimes, and that's when they call us. And so these are very, very frustrating because you know the patient's very sick, but you just don't have a lot of tools to do anything with. So 6 conditions that we talk about with shortness of breath. The first one is pulmonary embolism. Then the second is COPD, whether it's an emphysema or chronic bronchitis. Then we have asthma, pneumonia, congestive heart failure, and then there's hyperventilation, and that shows up as shortness of breath, but it's not really a respiratory problem. It's either an anxiety, emotional problem, or it's a metabolic problem. And so we're going to get to that. But basically, if you were to approach these lessons as, what's my patient going to complain of? Well, they're going to complain of shortness of breath. Okay, so what is that? Well, in the absence of trauma, it's one of these 6 things. So let's go through those. Pulmonary embolus. This is not an airway problem. This shows up as shortness of breath, but it is not an airway obstruction. It is a vascular obstruction. There is a clot or clots in the pulmonary arteriolar system, either in the pulmonary artery itself or in the arterioles that are just past the pulmonary artery. It is a vascular obstruction that comes on suddenly, and the patient may complain of immediate, sudden onset of shortness of breath. They may have some pain, some chest pain that is worse with breathing, so it's pleuritic chest pain. And this pain can usually be localized with one finger. They can point to where it hurts, whereas if they're having a heart attack, that's a general pressure, squeezing, aching sort of feeling. But the PE pain is much more localized. And of course they're going to be hypoxic, because even though their lung sounds are clear, there's not an obstruction in their airways. Their upper airways clear, their lower airways are clear, their alveoli are fine, but there's no blood supply going by, and so you have a large area of lung that's not being perfused, and so hypoxia will result just from that. And then the hypoxia triggers the dyspnea, and the patient breathes more rapidly in an effort to have the lung that is still in service working for them. This can turn into shock pretty quick, can turn into cardiac arrest. It's one of the causes of cardiac arrest. There are a list of 10 that we kind of touched on in cardiac arrest, and pulmonary embolus is one of the T's, a pulmonary thrombosis, and so certainly it's a cause of cardiac arrest, and these patients can be in shock. So what do you do for these PE patients? Well, you manage CVO as best you can, and these folks need to get going. We've kind of jokingly referred to that the treatment for a PE is O2 and diesel fuel, and there just isn't a heck of a lot else that can be done, even at the ALS level. The ALS folks may have the ability to add some IV therapy, some fluid support to kind of help support that preload for that right ventricle that's probably having a hard time pushing against the clot. But that is a minor assistance, and their plan is going to be about the same thing. Let's get going, which again is different than let's just go. Let's just go means you're not sure what to do and you're freaking out. There's nothing we can do for this in the field. This patient's at high risk for getting much worse, so let's get going. COPD, we can do some stuff for that. That's kind of a chronic situation, and what the patient needs is a new set of lungs, and we don't have those, so it's just kind of managing as best we can. They have some alveoli that are stiff. They have some that are destroyed. They have some bronchioles that are obstructed. They tend to have a fair amount of mucus, and they tend to get lung infections pretty easy. So is it pneumonia? Is it COPD? It's kind of a tough call sometimes. These are not a circulatory problem. The hypoxia that results from COPD is what causes cardiac arrest, but there's nothing wrong with their pump if it's just straight, simple COPD. And I'll touch on that again here in a second. So what do you do if it is just an emphysema flare-up, an exacerbation? You use O2 per your protocol. Pay some close attention to your O2 protocol on how to deliver oxygen therapy to COPD patients, chronic lungers. Ventilate as needed. Bronchodilators may help if they're prescribed for them and they're not expired and the patient's wheezing, or you believe the patient to be having a severe COPD exacerbation. You can go with the bronchodilators. And then there's something called PEEP, which is positive end expiratory pressure, which means a little bit of back pressure being supplied by a device, a mask, with a valve type device on it, and that mask is keeping the alveoli from collapsing completely. Collapsed alveoli is called atelectasis, and PEEP helps prevent atelectasis. PEEP helps recruit any available alveoli to open up and start working. If there is some lack of ventilation and the alveoli are not opening up, you add a little bit of PEEP to that ventilation, and the lungs will expand, and suddenly you'll have a lot more surface area to exchange gas with, and things will get better. At the BLS level in Missouri, you're not allowed to use PEEP. The patients themselves may have a CPAP or BiPAP device at home, and the ambulance service certainly does. So the big ALS treatment on the COPD side is bronchodilators like you can do, and then they add some PEEP via an appropriate device. Asthma sounds like COPD when you listen to the patient, but these patients' alveoli are just fine. It's not an alveolar problem, it's a bronchial problem. The bronchioles are constricted for some reason, inflamed as part of an allergic response, and asthma has a lot of allergic response to it, and then there's some mucus in there as well. And so the asthma patient really, if you can get those bronchioles opened up, the asthma patient will be okay. Their alveoli are not damaged. They don't need new lungs, they need their bronchioles to no longer be obstructed. Whereas in the COPD patient, they really have destroyed their alveoli and their bronchioles are obstructed. So with asthma, again, not a circulatory issue. If these folks do go into arrest, it's from extreme hypoxia. Use your O2 based on protocol. Most of these folks will not have lung disease as we define it in protocol. Asthma not being a lung disease per our protocol definition. It's not a COPD. It's not a chronic bronchitis, emphysema, or lung cancer. It is just bronchioles that are obstructed for one of those three reasons. So O2 per protocol, ventilate as needed, and use those bronchodilators if it's prescribed for the patient. On the ALS side, they're going to do bronchodilators, they're going to add steroids, and in some cases, in some services, they believe that PEEP helps, but usually not. Pneumonia, an infection in the lung. The alveoli are full of infected pus. The bronchioles are obstructed, and the alveoli are full of pus. The bronchioles are undergoing an inflammatory reaction. There's a lot of mucus down there, and when those things are present, sometimes the bronchioles get upset and they constrict as well. So pneumonia patients will wheeze in areas right before the area of consolidation in the lung. Consolidation meaning the lung is full of pus. So when you listen over that area of the lung, you don't hear any lung sounds, but when you listen nearby, you'll hear wheezes. Could be a circulatory issue. Pneumonia is one of the main causes of septic shock. Again, septic shock coming up in the next lesson, but what you end up with there is an inappropriate vasodilation. All septic shock is when your container's gotten too large. It's one of the distributive shocks. And so you may have a circulatory issue if the pneumonia turns into sepsis. And those patients can be very hypoxic and can go into cardiac arrest. Pneumonia can happen to anybody, any age. Tends to be a bigger deal in the older folks. Tends to be a great big hairy deal in older folks with lung disease already, where they don't really have the best lungs to start with because they have COPD or lung cancer. Then they end up with a pneumonia on top of it, and that can be fatal. Use your O2 per protocol. Ventilate as needed, and bronchodilators are okay if your patient's wheezing. So again, the general rule here is if you hear wheezing or you believe your patient has a bronchial obstruction due to bronchial constriction, then metered dose inhaler bronchodilators are usually okay, but you need to look at your protocols and see what standing orders are contained within them for assisted medication administration. All right, we're getting close here to the end. Congestive heart failure is when the alveoli are full of fluid from the blood. The bronchioles may be obstructed and upset, and they will constrict a little bit. This is a circulatory issue because that's the cause of it. And so you have the left ventricle not pumping adequately, blood is backing up, flooding the alveoli, and this is causing hypoxia because you don't have any way for air to meet with blood. The alveoli are full of fluid, and they're not meeting with the bloodstream, and we're not really able to transfer gases back and forth. So your patient gets hypoxic. Use your O2 and ventilate as needed. And again, if he's wheezing, bronchodilators via MDI, if they're allowed in your protocol, and it's the patient's, and it's not expired, then there's nothing wrong with that. They don't do a heck of a lot of good in CHF. CHF is a pump problem, and what the guy needs is a new heart, or he needs the one he's got to start working right. And so we're going to talk about cardiogenic shock here right quick. So why would somebody's pump fail? Well, it could be from just too slow of a rate. You know, somebody's heart rate's in the 30s or 40s is just not pumping often enough, even if they're pumping fairly strong. It could be also too high. Somebody's heart rate in the 160s or 180s, something higher than that. There just isn't enough filling time. And I think we've kind of talked about that, and you probably have a decent grasp of that concept. So it could be a rate problem. It could also be a stroke volume problem. It could be that the patient has had one or more heart attacks that has left an area of their left ventricle, a significant amount of their left ventricular muscle mass is no longer squeezing, it's just sitting there. And so it could be that the rate's too high or too low. It could be that the stroke volume, the pumping of the heart, is just not good enough. And so, you know, usually in shock, we say lay them down, keep them warm, all this. Keep them warm is fine, but laying them down is not going to fly with many of these folks until they are very, very sick. If a guy in congestive heart failure will let you lay him flat, then you might as well pull out your AED and get ready to code him, because they're going to go down pretty quickly. Bad CHF patients that are in cardiogenic shock, meaning they have CHF with hypotension, they don't want to lay down. And so try the position of least discomfort. It's not really a position of comfort because these folks are all over the place. They're literally getting too tired to breathe. So the ones that are bouncing around and very anxious and very air hungry are still working hard to breathe. Be careful, because as they start to wear out, they calm down and they look like they're getting better, and they're actually getting much worse, and they're getting ready to code on you. So these folks like to be sitting up. Keep that going, but then as they start to get much worse, they may need to be positioned more supine so you can ventilate. There's not a lot you can do at the BLS level. There's a lot of decisions to be made at the ALS level, whether you add fluid or not, whether you use medications and which ones and what types. And so the medics are thinking pretty hard on these, and these are judgment calls, and these are not easy cases to manage, and these folks are at a very, very high risk of cardiac arrest, and their 6-month mortality is really, really bad. So when you have a congestive heart failure patient who you would assess based on history and lung sounds of crackles, rowels, if your CHF patient is coughing up foamy, white, pink sputum, and they have very decreased lung sounds, and you can hear audible crackles, and then when you listen with a stethoscope, you auscultate crackles, and you're like, wow, this guy's in CHF, and he probably has a history of CHF, and so you have a pretty good diagnosis. But then his blood pressure can be quite high. They can be in the 190 over 110 range, or they can be in the 70 over 50 range. It's that hypotensive one that's in cardiogenic shock, and those guys are in big, big trouble. All right, wrapping up pretty quickly here. Hyperventilation is another cause, another condition that causes shortness of breath. It's not a circulatory problem. It's not a respiratory problem. It's either a metabolic problem or a psychological problem. Doesn't mean they're crazy. It means that they have experienced some sort of event that has caused them to breathe rapidly and deeply, and then this becomes kind of a self-fulfilling cycle. And the more deep and rapid they breathe, the more it kind of feeds on itself, and it's hard for them to slow down their breathing. Very, very difficult. That's for the anxiety cause. The metabolic cause, probably a little bit deeper than we want to get into in EMT class, but we still have to mention it. because I don't want you to think that everybody that's breathing rapidly and deeply, everybody that's hyperventilating, is from an emotional or anxiety cause. It could very well be a metabolic cause. It could be that they are septic. Again, next lesson we'll talk about. Could be that they are in something called diabetic ketoacidosis, DKA, which is extreme high blood sugar to the point where they're producing ketones in their body, and they are hyperventilating in order to try to fix a metabolic acidosis, a problem related to their metabolic system. So the respiratory system can fix some abnormalities in the metabolic system, and it does that with rapid and deep breathing. It could also be an overdose or some other toxin that's caused them to breathe rapidly and deeply, or it could be excited delirium syndrome. Excited delirium or agitated delirium, it's got two different names, means the same thing. This is the person who is very out of control, very difficult to handle, typically hyperthermic, not always, but frequently has used stimulants, and the call comes in for a naked guy running around beating on cars and acting crazy, and there's 6 cops trying to hold him down, and he's still fighting. And this guy will be breathing very rapidly and very deeply because he has built up so much lactic acid from all this muscle use that he has a metabolic acidosis. He has too much lactic acid, and his body is trying to compensate for that by having him breathe rapidly and deeply. The respiratory system trying to fix a metabolic problem. And the thing is that we need to restrain this guy. We need to not impair his ventilation. So anyway, hyperventilation, shortness of breath, could be an emotional cause, could be a metabolic cause. It's not a respiratory thing. Nothing wrong with their alveoli, nothing wrong with their bronchioles, nothing wrong with their cardiovascular system. O2, as per protocol, is fine. There's nothing wrong with giving them oxygen. It's just not getting anywhere if they are on the anxiety side. And on the metabolic side, the hyperventilation is what's going to fix them. So just maintain their O2 saturation best you can. Treat that emotional cause if possible. This takes a while. And on the BLS side, you probably can't do much about that metabolic cause. So the hyperventilators are really kind of frustrating. Your assessment of shortness of breath. You need a history and you need a physical. History and physical. And that history is both past history and the history of the present illness, or the HPI. So what happened? What's going on? What were you doing when this started? What have you been doing today? What past history do you have? You can already see the sample history questions fitting in here. And then a physical exam has got to include lung sounds. Probably should include a look for jugular vein distension. Probably should consider cardiovascular issues as well. But for certain, you need to get the lung sounds. So what do they mean? Well, wheezes are high-pitched whistling sounds, can be on inspiration or expiration. Bronchodilators work for that. Crackles, which sound like crackles, and used to be called rales, R-A-L-E-S, and some people still say rails. But crackles is an actual medical term. It's fine to use that. And you can sometimes hear those without a stethoscope. But then when you listen with your stethoscope and the patient takes a deep breath and you hear crackling at the end, then think that's either CHF or pneumonia. It could also be diminished lung sounds. Diminished is a lung sound in that they're not moving as much air as you would expect. And you listen and you just don't hear good air movement. Again, think CHF or pneumonia for that. Or they could be clear. Now, clear is not quiet. Quiet means you don't hear anything. Clear means you hear good air movement with no extra sounds. No crackles, no wheezes. Clear. Clear lung sounds in a patient that's short of breath is either a pulmonary embolus or hyperventilation. But quiet lung sounds could be very bad for any of these, and it means that where you're listening, there's no air exchange. So very bad pneumonia, very bad asthma, very bad COPD, very bad CHF. Any of those are dangerous. So as you treat your patient gets better, they tend to get louder. They weren't moving any air, now they are moving air, and now you start hearing wheezes. That's actually a good thing. So quiet lung sounds are scary. And in general, your treatment, oxygen per the protocol, ventilation as needed, bronchodilators when allowed. Anytime you think there's wheezing or bronchial constriction, go for those bronchodilators, and here they are. So, albuterol is the generic name of the medication, and the trade names that are common are Ventolin and Proventil and ProAir, and these are can be delivered via high-flow nebulizer, which you can't use, or by metered dose inhaler, the puffer, the inhaler, the MDI, which you can use. Sometimes a patient will be taking a medicine called ipratropium, which I mentioned earlier, and that is the generic name. The trade name is Atrovent, and then when you mix ipratropium and albuterol, you get a combination called Combivent, and another brand of that is Duoneb, and you're okay to use those. So you can use any of those that are albuterol or ipratropium containing, and those are their rescue inhalers, and those are okay as long as your protocols contain standing orders for assisted medication. As long as it's prescribed for the patient and it's not expired, you're good to go with those. Now, again, not all MDIs are bronchodilators. They take things that are steroids. There's a gajillion of those, and when in doubt, it would be okay to go ahead and use the MDI when in doubt, but you should investigate and attempt to make your best decision. If you're stuck and you're just not sure, well, go ahead and use the steroid. Bronchodilator is just not going to do anything right now. So they usually know, yeah, this is my rescue inhaler. This is the one I take when I'm in trouble, and otherwise. Now, why would a patient not have taken their inhaler if they have it with them and it's not expired? So why would you ever even get into this assisted med thing? Well, they'll typically take some doses of their inhaler, and if they're just dead spacing that medicine, if that medicine is not getting down to the bronchioles, the terminal bronchioles, and down toward the alveoli, if it's not getting way down the tree, then they're just dead spacing it, and it's not doing any good. And so it could be technique on their part. It could be that they're breathing so rapidly and breathing shallow that they're not getting the medicine all the way down there. So it could be the dead spacing. Medics will use the same medicine. They'll do it by high-flow nebulizer. They may add some PEEP. They may add CPAP. They may go to advanced airways. And they also have the ability to use injected bronchodilators given via IV. So, quick summary, we're right pushing the 20-minute mark, which is my max. And so, here's the deal on shortness of breath patients. Position them as they can tolerate. If they want to sit up, let them sit up. If they want to lean back some, let them lean back some. Use your protocol for oxygen. Know your protocol for oxygen. Know what you give to a patient with lung disease, what you give to a patient without lung disease, and if it's based on a pulse oximetry, know those values, and never, never, never withhold oxygen from somebody that you think needs it. Ventilate as needed. Remember that this is not just about the alveoli and oxygenation. It is also about ventilation. Both of those need to be involved, and so if your patient's breathing 3 times a minute, even if he has patent airways and has no obstruction in the upper or lower, he's not moving enough air per minute, and so ventilation may be needed. And by the same token, you know, if your patient's breathing 50 times a minute, it's really unlikely that he's breathing deeply enough, so you may need to work on that. Get a history and physical, both past history and history of the present illness, and do that physical exam. You're going to need to listen to lung sounds and to make some decisions. You're not going to be able to give the MDI bronchodilator unless you've got suspicion of bronchoconstriction and you've been able to hear some wheezing. So that's pretty much it. We see a lot of shortness of breath patients. At the BLS level, we have a couple of tools. We don't have a whole bunch of tools. And the oxygen is driven by protocol, and then the bronchodilators are, if allowed by protocol, then the thing there is you must believe the patient needs it based on their condition and the wheezing, and that you have the right bronchodilator MDI. You're not giving them a bunch of steroid stuff. So we'll play with this in lab, and we'll see you then.